All right, we're unmuted.
Okay. Hey, folks, we're going to get started here. Welcome back to our current iteration of the Easie Echo, or the Education and Antimicrobial Stewardship and Idea Exchange, now sponsored by Echo, as it were. We don't have Sharon Gibson, our babysitter, who keeps us in line usually, so I'm going to actually just read off a few things on some housekeeping requirements so folks are aware. First, just want to remind folks that this is a monthly session, Wednesday at noon. Really focused to be on antimicrobial stewardship team, so we can get some idea exchange and share some current updates for ID and stewardship issues. And most importantly, really want this to be interactive and have folks share projects, et cetera. We have a good opportunity for that today. So quick reminders. It looks like most of you have already put your name in there, but if you haven't, put your name. And actually, we'll leave the institution profession. Name is enough, and that's a requirement of our agreement with the Echo Institute. They're tracking numbers for that.
So submit your name in the chat function.
Yeah. So when you sign in on the Zoom, and you have an option on the chat, just put your name on there so we know who you are. If you want to put your actual location or title, we'll take that too, but at least put your name on there.
So send your name in the chat function to the Project Echo chat, if you will, and that helps us take attendance.
Thank you. Reminder: we really would like folks, if they can, and don't be shy, and go ahead and put your video on, like Mary has already done, so we can have this collegial discussion. It sort of helps with the flow. And also, if you can keep yourself on mute unless you're speaking, and if you're on the phone calling in, hit your *6 to unmute and mute, depending on whether you want to be heard or not. And lastly, actually 2 more items. If you have a comment or question, feel free. You can raise your hand. If you're on video, we'll see you raising your hand. If not, you can send a chat to the Project Echo Program Administrator listing on the chat box. And then, kind of an important part of this, and I don't think we have any issues here, but remember, this entire Echo session is always a PHI, Protected Health Information free zone. There's no exchange of patient information or PHI. And then we'll do a few announcements at the end, just to remind folks how they can get links and access to the talks, et cetera. So today's session, actually, they can see the screen?
Yeah.
Okay, so this is our session for today. Shorter is better. Mary Hutton is actually our stewardship lead, our PharmD champion at Utah Valley, and she's going to talk about short course antibiotic therapy for CAP. But first, we have one important announcement that I'm going to turn that over to John for.
Sure. So just real quick introductions. That was Todd Bento, Medical Director, ID Telehealth. And this, I'm John. I'm the ID Telehealth Pharmacist. And then in the room is Mary, our Infectious Disease Pharmacist from Utah Valley. Before we get started on community-acquired pneumonia, I wanted to say a quick thank you to Jenny Barlow, the Stewardship Champion at Riverton. Unfortunately, she is leaving Intermountain for a new job. So we are very sad to see her go, and just wanted to take a second to recognize her numerous accomplishments while she was at Riverton. So in participating through the SCORE study, she was able to accomplish a significant reduction in broad-spectrum antibiotic use following the SCORE study. She's had numerous great catches for patient safety and stewardship. Her QI projects include the ED results callback process, meropenem MUE, and she's currently working on blood culture contamination reduction and decrease in asymptomatic bacteriuria treatment in the ED. So I didn't want to embarrass her in front of the group in case she's called in today, but just want to take a quick second to say thank you to Jenny as she's transitioning to a new job. So thank you.
Okay.
All right, on to our feature presentation. Thank you, Mary. So again, Mary is the ID pharmacist at Utah Valley and a video game enthusiast. So please feel free to ask her any questions about either of those things. So let's hear about CAP from Mary. Thanks. Take it away.
Thanks for that introduction. Please write in the chat if you can't hear me very well. I'm going to be speaking over the speakers in the room, so I just wanted to make that announcement. So community-acquired pneumonia is a huge problem at any hospital, small or large, and any type of physician is going to see this disease state. In 2016, influenza pneumonia ranked number 8 in the leading causes of death in the United States, and approximately 1 million people seek hospital care for pneumonia annually. And finally, it's the number 4 diagnosis related to hospital admission in adults in 2015. It's just, I know, hard.
Can you keep going?
No.
Oh, hang on one second.
We're gonna switch out monitors here. Just bear with us for a second, folks. We're gonna solve a laptop technical difficulty. Sure. Actually, if you want to say here for breakfast, if he doesn't, then we can here. And then we'll just keep talking.
Yeah.
Okay. While we're waiting for that to be fixed, feel free to come up with any questions that you have regarding, or start thinking about issues that you've seen in your facilities regarding how to get to short course therapy, and maybe even think about some specific items like what happens when you transition to discharge. So that as we've seen it, those are opportunities for folks to make an intervention on shortening course of therapy.
Right,
I'm going to turn it back over to Mary.
All right, sorry about that. I think my laptop might have died. I'm not sure. So duration of therapy is a huge problem, I think, across the United States. And from this study in 2018, looking at private insurance versus Medicare insurance, it didn't matter which one of those, the length of therapy greater than 7 days was about 70% in both of those patient populations. And as we know from the guidelines that recommend about 5 to 7 days, over 70% of our patients are getting more than that. And there is a lot of evidence to support short course therapy for this disease state. And I wanted to delve in a little bit into those studies, but first wanted to go back to the IDSA community-acquired pneumonia guidelines. So they do state, and this is the old guidelines, we are looking forward to our new guidelines, which should be coming hopefully shortly, that a patient with a community-acquired pneumonia should be treated for a minimum of 5 days. That patient should be afebrile for 48 to 72 hours, and they should have no more than 1 community-acquired associated sign of clinical instability before discontinuation of therapy. And these signs of clinical instability would be patients with a fever, patients with a heart rate greater than 100, respiratory rate greater than 24, a systolic blood pressure less than 90, an oxygen saturation rate less than 90%, on room air, but also remembering that for patients that are on oxygen, as long as they get back to their normal oxygen that they were requiring at home with that oxygen saturation. Then finally, inability to maintain oral intake or altered mental status. So basically our patients are ready to go home, or they're close to be ready to go home. The first study I wanted to talk about was with the fluoroquinolones with Levaquin, and this was a randomized controlled trial of 392 patients. And it looked at Levaquin for 5 days versus 10 days, and it included patients that had pneumonia. So these patients had fever, they had a white blood cell count of greater than 10,000, or a bandemia. And what they saw was that between 5 days and 10 days, there was no difference in the entire population, about 90% having clinical success, and patients with more severe pneumonia, so PFI of 3 or 4, and then again in our elderly patients. And then also it didn't matter if the patient was infected with strep pneumoniae or atypical pathogens. Again, there's no difference between 5 days versus 10 days. Noting that the 5-day dose of levofloxacin was 750 milligrams compared to 500. This was repeated in China in 2 different studies. So in the first study in 2014 by Zhao and colleagues, they looked at IV levofloxacin 750 milligrams for 5 days versus IV 500 milligrams for 7 to 14 days. Again, they saw no difference. In 2016, they repeated the study, seeing if maybe they could step down to oral if there'd be any change. And this is at any time that the provider felt appropriate. So again, they saw no difference when they stepped down from IV to oral therapy, looking at 5 days to 7 to 14 days. That's talking about fluoroquinolones, and we really don't have any beta-lactam studies, randomized controlled trials in the United States, but this was done in the Netherlands with 119 patients. You do have to remember that the Netherlands patient population is a little bit different than the United States. They don't really see as much resistance, and the patients are a little generally healthy. But what I took away from this study was that It's important to remember the adverse effects of antimicrobials. So these patients all got 3 days of amoxicillin, and then they were randomized to get placebo for 5 more days or continue amoxicillin for 5 more days. There was no difference in success at 10 or 28 days, but what they did see that there was a doubling of adverse effects for the patients that got amoxicillin for those 5 additional days, for 11% to 21%. And again, there's even more data to support short course therapy for community-acquired pneumonia. Again, most of these patients, as you see, got a fluoroquinolone at 80%, but I don't really think that can change the outcome if we use things like augmentin or macrolides here. So this randomized controlled trial was 312 patients. At 5 days that the patient was afebrile for 48 hours and did not have one more of those clinical signs of instability that we talked about, the patient was randomly assigned to stop antibiotics or continue per provider discretion. These patients are what we would expect to see in the hospital, about 65 years old, 20% were smoker, about 15% had COPD, and their PSI score mean was 83, and what that means is these patients didn't really have severe pneumonia. They were more on outpatient or a short course inpatient therapy that we would expect. Most of the patients had streptococcal pneumonia, which we would expect. Legionella, like I said, most of the patients did get a fluoroquinolone at 80%. We would expect for the patients that were in the control group to have a longer duration, which they did at about 10 days compared to 5 days in the intervention group. And there was no difference as far as how many days of IV therapy patients got. So that was about 2 to 3 in the control group versus the intervention group. And starting on the left, there was no difference in hospital mortality. There was no difference in reoccurrence. There was no difference in readmission at day 30. And in this study, there was no difference in adverse effects. And then on the right, the clinical success, there was no difference in clinical success or 30-day clinical success. So again, this is the final study I'll show you, but I really think that there's a lot of data to support short course therapy, looking at 5 days versus a longer course of 7 to 10 days. And I think I would be amiss not talking about procalcitonin for this patient population, but again, this could be an entire presentation on itself. But there are recommendations to say that antimicrobials can be discontinued in patients with a procalcitonin less than 0.25, or if the procalcitonin has decreased 80% or greater. And I think that's important to remember, because even if a patient has a procalcitonin of 1.2, if they came down from 50 and they're at day 5, day 7, I think it'd be safe to say we can stop antimicrobials in that patient. But they do recommend that regardless of procalcitonin, continuous antimicrobials beyond standard duration of therapy is not recommended. And really the guidelines are going to focus on clinical stability criteria that we talked about rather than procalcitonin levels. And I think it's important to remember that for some patient populations, procalcitonin can be elevated at baseline. So important to take that all into account when we're looking at procalcitonin. So we'll go on to a patient case and we'll talk a little bit about this and have some discussion. So I made up this patient case, but it's something commonly we'll see in the hospital. So SJ is a 76-year-old male. He's admitted to your general practice floor with 3 days history of cough and fever. His chest x-ray revealed a left lower lobe infiltrate. He started on ceftriaxone 1 gram IV daily and azithromycin 500 milligrams orally daily for those 3 doses, and he started on oxygen at 2 liters. So on admission, he is febrile. His white blood cell count is 17.3. His heart rate is 98 beats per minute. His respiratory rate is 21 breaths per minute, and he's saturating 85%, and that's on room air before they started him on oxygen. But on day 3, the patient has deprivessed. His white blood cell count is normalizing. As you can see, he's down to 13.4. He's finally off oxygen. He's still on his ceftriaxone 1 gram IV daily, and his last dose of azithromycin is today. Heart rate, 96 beats per minute. His respiratory rate is 20 breaths per minute, and he's saturating 92% on that room air. So what would you do for this patient, and what recommendations would you make to the physician, or you as an ID physician recommend to the floor physician? So would you switch to oral amoxicillin for 2 more doses to give him a 5-day total? Would you switch to oral amoxicillin for 4 more days to do a 7-day total? Would you continue IV ceftriaxone for 2 more days to hit that 5 days total? Or would you stop antibiotics altogether?
We'll leave that poll open for a few minutes with the case up there and give you guys a second to think about that. And we would love to hear your thoughts on this too. All right, so this is what you guys said. It looks like, oh, go ahead, Mary.
Yeah, so I would agree with the first one, but I would love to talk about the other ones as well. So switch to oral amoxicillin for 2 more days. I think this patient has shown that he has clinical signs of stability. We can switch him over to oral and set him up to get ready for discharge. But switching to oral for 7 more days. Any thoughts from the group? Or 7 days total?
Yeah, so any thoughts on the phone on completing 5 versus 7 days, or any thoughts on duration?
Yeah, so folks, if you, we'd really love to have your input so we can kind of help share how folks are experiencing this and opportunities for making this better at different places. But so anybody else on the phone, if you want to chime in, don't forget to *6 unmute.
Yeah, hey, this is Rob from LDS Hospital, and honestly, I chose the 5 days mainly because of this conversation right now. I would have chose the 7 days, you know, because of, you know, maybe a little bit more of the temp and heart rate. I mean, everything else looked okay according to what the diagram before showed, but I would have done 7 days before, but I chose the 5 days because of this conversation we're just having right now.
Awesome.
Gotcha. So you just want to repeat what he said?
Yeah. So it sounded like he said that previous to this conversation, he would have picked 7 days. Airing more if, you know, his heart rate is still a little bit elevated, although he's still under 100, and his temperature, you know, is kind of borderline. But after talking about, you know, he really actually does meet all those clinical stability criteria, that 2 more days is probably sufficient for this patient.
Great. Any other thoughts on the phone? Thanks so much for sharing, Rob.
What about those that would want to complete 5 days total of ceftriaxone IV?
But this is Tom at Orem. I guess I was on mute. Anyway, I agree with Rob. I would have gone 7 days before hearing what I've heard already. So.
Yeah. Any thoughts on completing the course with IV versus oral, Tom?
Well, you know, everybody that's that sick at Orem, we send them to Utah Valley so that Mary can take care of them down there.
So I can deal with it.
She can stop the antibiotics at that time.
So yeah, we'll defer to Mary on that one. So. Yeah.
Well, I would say that this patient kind of sounds like they're almost ready to go home. So rather than put a PICC line in a patient for community-acquired pneumonia, I think that we have enough data to say that finishing out oral would be more appropriate. And we all know that PICC lines can come with their own adverse effects. So that's why I would want to switch to oral faster. Who wants to stop antibiotics altogether?
And any votes? A couple of you voted for discontinuing antibiotics. Any thoughts on that?
I think that's a hard thing. I think the guidelines do recommend at least 5 days, and I think we'll continue to see that until we have more literature about super short therapy. That's what I think 3 days is. I think there's more to come.
Mary, can I ask a question? I wouldn't even think on this particular patient to keep the IV antibiotics on, but at what point would it be recommended to keep the IV antibiotics on, or would it really at all be ever an option?
I think, well, I didn't catch the last caller.
That was Rob.
Oh, Rob, sorry. Yeah, this is Todd. And I hope I don't misunderstand, but you were asking in what situations would you just complete the final 2 days with IV? And it, you know, clinically for us, what it often comes down to is the issue of PO intolerance and, you know, concerns for that with the patient, and that's where I would consider that. I think this is an opportunity this day and age, this past year in particular, to seize on this moment in time to talk to providers about these opportunities to switch. And rarely do I have that scenario come up where they can't go to PO. There are certain situations, but a lot of these folks are pretty much ready to go out, and they try to figure out whether they're going to come back in to get an IV in the infusion center and an IV in the infusion center for 2 more days, which really I would try to discourage them from doing that.
Yeah, I mean, we generally think about contraindications to oral therapy, like inability to take oral, or maybe a patient with short gut syndrome that isn't able to absorb oral medications. Those are maybe the rare situations that I would not switch. But for the majority,
majority I would switch.
For the majority, I would strongly consider switching to oral. Yeah, great question, Rob. Other thoughts? Okay, we'll have more time for Q&A at the end, so we'll keep on going. Mary has some awesome data to share with us.
Yeah, so I wanted to show you guys kind of what's happening at Intermountain across all the facilities, and I think it's really interesting because we have quite a spread of really what's going on. So for this first slide, it's a little busy, but I'll walk you through it. So this is duration for community-acquired pneumonia. In blue, we have the days of therapy, and the left side would be the average duration. So the blue line going up would be your average. So let's take American Fork, for example. Their average looks about 9 days. So, and then in the orange would be the number of patients that were evaluated so per each hospital. So American Fork about 9 days. And as you can see across the board, we're really about 8 days or more for most hospitals. Down in San Pete, we're at 4 days, which is interesting. And I would love to hear about what's going on at San Pete and the things that they're doing. But we really wanted to talk about kind of what each hospital is doing, where you're making these interventions, how things are happening as outpatient. And I bring up outpatient because most of our durations are actually influenced by what is given as an outpatient. So in blue, again, the same numbers that we saw before, average total duration of days. And then in orange would be the average outpatient duration. So as you can see for most hospitals, it's half or more than half for that total average duration. So we'd love to open it up to the floor and talk about what's going on at each hospital, where you think maybe we can make some improvements, or just what's going on.
Yeah, that's great. I think I did actually see Wes on the phone. Wes, if you maybe want to comment on maybe your provider's practices for treatment of pneumonia, since you guys seem to have pretty short duration. Just remember to take yourself off mute if you're still logged in there, Wes.
How do I take, can you hear me now?
Yeah, we can hear you.
Oh, okay. I don't know if I can speak to this exactly, but I do know that we stop antibiotics if they find that it's viral or something. So maybe that one was just miscoded at first, because I can't say that we usually treat for 4 days.
Right. So I, having helped out with some of those chart reviews, I know some of those, I think we excluded the ones that turned out to be viral. I think some of those patients may have received a shorter course of like a macrolide or quinoline for an atypical pneumonia, which those durations tend to be a little bit shorter. But any comments on how you have that conversation with the local docs there?
Oh, our doctors are fabulous to work with, so they love using you guys' service too. So very easy to review these standards with them and make sure that we're doing the appropriate length. So I don't have a lot of pushback anymore with who we have as hospitalists on following the guidelines.
Great, thanks so much, Wes. Any other folks on the line? We'll open it up. Any comments on how you approach having these types of conversations on duration of therapy with your providers?
This is Tom at Orem. On the duration, is it with a single medication or dual medications? Does this analysis look at how many were prescribed two types of things, like a macrolide and a beta-lactam or a quinolone, or would that affect the duration of therapy?
This was total duration for all antibiotics. If they were on multiple antibiotics, it still would have just counted as 1 day of therapy. Yeah. So we just looked at total number of days that patients were on an antibiotic, both inpatient and outpatient combined.
I was going
So
to.
you're,
Go ahead,
are you
Tom.
pulling, no, thanks, doctor. So you're pulling the information from prescriptions being filled at our local pharmacies too, that are outpatient, that were not hospitalized?
This was based on hospitalized patients. Sorry, I should have clarified that. So it was based on patients who were admitted to the hospital. I believe it was based on ICD-9 code for community-acquired pneumonia. And then we went through and did some manual data validation to make sure that those patients did indeed have community-acquired pneumonia. We excluded folks that had hospital onset pneumonia or more complicating factors. So it should be a fairly homogeneous patient population with community-acquired pneumonia admitted to the hospital. Then we looked at total inpatient and outpatient days of antibiotics combined.
Okay. The reason I say it, we have a family member that recently was diagnosed by the primary care doctor with having pneumonia that, because of saturations, was on the border of being admitted to the hospital. But wanted to try to treat outpatient. And in that case, they gave the normal Z-Pak 5 days and then 10 days of Sednifer for the beta-lactam type treatment. But that was a 10-day course of Omnicef to be treated along with the azithromycin. That's what kind of prompted my question. So,
do you want to comment on that?
Yeah, outpatient primary care is a whole large beast that we've yet to tap into to see kind of I think we know what's going on. But as far as my work inpatient, I don't have the ability to be able to monitor all the clinics down in Provo as well as inpatient. But
yeah,
as a system, we're definitely looking to see what's happening in the clinics and seeing if we can make interventions there.
Yeah, I mean, I think historically the treatment durations were 10 to 14 days, and that's really just based on convention and a lack of clinical data. But based on some of the data that Mary's provided, and it's now being reflected in the guidelines, shorter courses are equally effective and cause less side effects for the patients. So I think that's a good opportunity. When you are able to have those conversations with your local providers or even your own primary care doctor, those are good opportunities for education on the new guidelines.
okay, thank you.
Thanks,
Hey,
Tom.
this is Rob again. I do have a question because isn't the current recommendation 7 days?
5 to 7.
Yeah, so the current guidelines say a minimum of 5, and that's assuming that the patient has met clinical stability criteria.
So, because I mean, I'm looking at it, and what I'm wondering is basically because all the algorithm treatments all says 7 days. Is this something that we should be talking to them about right now, about moving to 5 days, knowing that our care process model says 7? Or is this something that we should, because we're closer to 10, so we can at least try to get them down to 7. But what are your thoughts on that?
We may need to update the care process model, Rob. That's a great point. I think, yeah, it's completely reasonable to have the conversation now. We have the data published, and assuming that the patient in front of you is clinically improved, extra days of antibiotics may not help. So yes, you're absolutely right. A good conversation to have now. Todd, any thoughts on that?
No, I agree with what John said. I was going to push this as we're getting close to the end of our time, and I really appreciate people being interactive and helping with the discussion. But I do want to talk about opportunity here. If you look at the graph and how it shows outpatient duration and total, this seems to be a nice opportunity at many places to have that conversation. So different than the conversation about telling docs up front that, hey, it's 7 on the CPM or it's 5 minimum, and we can look at that. That's the education part and awareness. But now when you're seeing this on your vigilance tracking, or if you happen to know, since it's a small facility, that 2 people are leaving and you've seen it been on X days so far, do you see an opportunity, or how are people approaching that when they see a chance, a moment in time for them leaving the hospital to do something about their duration? Anybody have any experience with that or want to share success stories? So anybody on the phone, don't forget to unmute, *6. How about anybody on the video or the call-in? And then I'm going to ask people in the room if they're married. Any comments about that at your facility?
So as you can see, we're about 8 days, with 4 of our days being prescribed on discharge. And I struggle because I'll come in the next day and the patient's already gone, when I had planned to, talk to the next day about just stopping antibiotics altogether. And so I think that's kind of where I struggle. We have these meetings every day where the patients are talked about discharges for our social work and things like that. So I think getting into that meeting with pharmacy and the physicians and discussing, how many days, if they don't need IV, how many more days of oral, and we can already have that discussion because they're already talking about discharge and where they're going. So I think in that meeting would be a great opportunity, at least in my hospital. I don't know if any of the other hospitals across the system have that for the patients, but I think that's a great opportunity.
Yeah, just looking at the graph up here, it seems like outpatient, like the duration of outpatient prescription might be the lowest hanging fruit, and that's a simple conversation, having that education with the physician about how long they're giving outpatient. After
it's okay to give 1 day of antibiotics. Yeah. It really is okay.
Exactly. So I think especially for the hospitals on this graph that have longer durations of therapy, I think this is going to be good data. It's easy education to give to your local providers and let them know that they're outliers in terms of duration compared to other hospitals in the system. From small hospital perspective, I'll plan on reaching out to some of these hospitals on the graph that have longer duration, see if you'd be willing to share this data with your local providers. So I think this is maybe a low-hanging fruit, easy win type of intervention to make in terms of stewardship.
Absolutely. And if you can get in a hospitalist meeting or something like that, I'm going to be at one tomorrow. I think that's also a great opportunity. This is a one-slide thing you can show someone that can make a big difference.
Absolutely. Okay, so we have a quick question from Chad about dalbavancin. Chad, I'll get to you after the call.
There you go.
Yes, I will look at that patient for you.
We're going to strike that dalbavancin comment from the actual talk.
Yes.
Actually, I'm going to start to wrap this up. I do want to give one last opportunity for anybody on the phone who's looking at the slides, if they want to, any last comments related to this or other topics before we wrap up here. Don't forget to unmute.
So this is Tom again at Orem, and I want to just make sure I'm clear on my comment to Mary about sending our sick folks to them. We do not have pulmonologists or an intensive care unit or a medical unit, really. So when our emergency department diagnoses a pneumonia and feels there needs to be an admission, that's what they need to do, is determine the location to send them to. We just are not staffed here. That's why on your graph, there's nothing showing Orem, because we just don't have those patients admitted here because of those resources. So anyway, we really appreciate our partnership with Utah Valley. So
thank you.
Well, thank you, Tom. And also thank you for the others who chimed in and kept the discussion lively. We really do appreciate that. And lastly, I do want to thank Mary for coming all the way up here from so far down south to actually share this data on duration of therapy. It's really important, and you'll hear a lot more about that. And as was alluded to, maybe some more information regarding CPM changes, care process model changes for pneumonia. I do want to make a few final housekeeping. Any comments on the room or question?
Yeah.
So if you have requests or suggestions for future didactic topics, you can submit them via email to the Intermountain Project Echo. All one word, intermountainprojectecho@iml.org. We will be sending an email for announcing access to this, or we'll go through.
Yeah, so once we have the recordings posted online, we'll send an email just reminding folks where to access those. Yeah.
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 And then lastly, you know, we certainly want to grow the program, and we've offered it through other email services to providers in addition to pharmacists, and anyone's welcome. So please share this information. We'll be expanding our email group each month, but you're welcome to share this with others, and we'll take all comers.
Absolutely. We have one last question from Steve down in Garfield. Hey, Steve. It sounds like you're wondering when we're going to update the Intermountain Care Process Model. I don't have a good answer for that. Those processes usually take a lot of time, but it is on our radar. And I think it's, based on our discussion today, I think it's definitely an important thing to be working on in the near future. So we'll certainly bring that up to the folks who developed the current version and see if they'd be willing to give us a timeline for updating it. But just know, based on the data, that you are supported by the ID services and by current literature in giving short courses to your patients. So feel free to call us if you have questions on that. Mary's available as a resource, and Todd and I are as well. So thank you, Steve, for the question.
Thanks, Steve. All right, I'm going to go ahead and wrap up, and we'll be back on in March, fourth Wednesday. I don't know our topic teaser.
I forget our next topic, but we will let you guys know.
We'll send out an email teaser on the topic, and we'll get you an announcement for the next time before the day of. So thanks again, everyone, for joining.
Thanks, guys.
Thank you.
Thank you.